Hello, I'm Dr. Mark Gold, and on behalf of CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity titled Opioid Use Disorder in Special Populations, Making Recovery a Goal. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians across the globe. Also, today's program has been designed to meet the requirements for both MOC and MIPS improvement activity, your active participation, answering polling questions, asking a question, completing the evaluation, and post-test is the first step in the process. After today's program, actively work to incorporate the clinical improvements we discussed, and in 3 to 4 months, CME Outfitters will send you a survey to complete, which will fulfill the data collection requirement. You'll then receive a confirmation you can submit to CMS. As I mentioned, I'm Dr. Mark Gold. I'm a winner of the ASAM Annual Lifetime Achievement Award, John P. McGovern Award, and currently an adjunct professor of psychiatry at Washington University School of Medicine in St. Louis, Missouri. I'm looking forward to our discussion, which will focus on opioid use disorder in two special populations, veterans and individuals in the correctional system. So let me introduce our faculty joining me today. First, let me welcome Dr. Brian Ferlin, Assistant Professor of Psychiatry at Yale University School of Medicine and the Director of the Psychiatric Emergency Room at the VA Connecticut Healthcare System in New Haven, Connecticut. Thanks for being here, Brian.
Thank you. Pleasure.
Also, let me introduce to you Dr. Tom Costin. Dr. Costin is the J.H. Wagner Chair and Professor of Psychiatry, Neuroscience, Pharmacology, Immunology, and Pathology Director, Division of Addiction Psychiatry, Baylor College of Medicine, Houston, Texas. Welcome, Tom.
Thank you.
Also joining us via remote links are Dr. Tobias Wasser. Dr. Wasser, the Chief Medical Officer at Whiting Forensic Hospital in Middletown, Connecticut, and Assistant Professor of Psychiatry at Yale University School of Medicine and Associate Director, Yale Fellowship in Public Psychiatry in New Haven, Connecticut. And finally, earlier today I interviewed Dr. James Berry, Associate Professor and Vice Chair of the Department of Behavioral Medicine and Psychiatry, the Division of Addictions at West Virginia University, and you'll see parts of that discussion integrated throughout our program today. So let's get started. We'll first review our learning objectives. Our first objective will be to recognize the risk of relapse and death among incarcerated individuals with untreated OUD upon release. Second, we'll focus the data for medication-assisted therapy among two special populations, veterans and incarcerated individuals, and how to apply that data to decision-making in OUD. Finally, we'll take a look at some of the best practices and novel programs in the community that everyone can integrate into their own practice. So let me set the stage. In a recent review by Pitt with an experimental modeling, and this is a really great group out of Stanford where Humphreys has done his work. They projected without any additional interventions the number of deaths which would occur in the United States at 510,000 from 216 to 225. That's totally unacceptable. And within this review, they point out that things that we could do to make things better, one of those being implementation of MAT, which we'll discuss today, another being the widespread use of Narcan, naloxone, which we'll discuss today as well. Opioid use disorder is so very common, but generally misdiagnosed or not diagnosed at all. For each opioid-related death, it is estimated that 20 to 30 people overdose on opioids but don't die. So it's very, very common. MAT medications, while available and approved for use by the FDA, are only given in less than 25% of publicly funded opioid treatment programs. So as a starting point, let's get an idea on some barriers to MAT prescribing in your own practice. So there's a polling question on your screen. and we'll ask, what is your biggest barrier to using MAT for patients with OUD? And these are the choices: A, education about appropriate prescribing; B, lack of patient demand; C, time; D, insurance reimbursement; and E, I do not support the use of MAT. So please answer now, and I'll be sharing the results with you and our panel shortly. Brian, we know there's an opioid crisis in our nation, and maybe we've never even seen anything close to this before. What could you tell us about the long-term outlook for someone with an opioid use disorder?
All right, thanks, Mark. This is a study that was done over 30 years, which is a fairly unique study to follow people for so long. And at the beginning of the study, the average age of the person was about 25 years old. And they followed people for 30 years to see how they would do. These are people who had an opiate use disorder. And they just followed them. Some went to treatment, some didn't, just a natural progression of the illness. And it turns out, you can see on the graph, that at the end of the 30-year study, almost 50% of the people enrolled in the study had passed away. That is 50-50 chance of making it into your 50s, starting at the age of 25. And then those who were alive, there is a variety of other consequences. Some were incarcerated, some were continuing to use. There was approximately a 22% chance that you'd be alive and sober, abstinent of drugs, at the 30-year mark in the study. To put that in perspective, there aren't that many other illnesses that impact 25-year-old people that carry a 50-50 chance of making it to your 50s. And if you do, you're very likely to have some other significant consequences associated.
Well, that's really sets the stage for a chronic, lifelong series of challenges for the person who's an addict. What about the people around them?
Right. So the financial burden of opiate use disorder is astounding. To think of what goes on behind the scenes, the infectious diseases, the accidents, the incarcerations. There's a huge financial burden, and you can see on the slide just a little bit about that. But children are involved as well. Family members who have an opiate use disorder have much higher rates of having their children be involved with the foster care system. Anyone in the audience or anyone out there who's ever known or been involved with a loved one or personal family member or friend who's struggled with an opiate use disorder or any addiction at all can truly attest to the fact that this is a family problem, that everyone in the family will suffer the consequences of their loved one having an opiate use disorder, really unlike any other illness out there. So we have the individual, which gets affected over a period of time, we have society, which gets affected, and we have the families, which get affected.
Thanks. Tom, we mentioned briefly the Stanford Humphreys group looking at the tragic deaths and disability and what we could do about it. McKinsey has a recent report as well looking at the opioid epidemic and why we need bolder action. What do you think about that?
Well, it was a very comprehensive report that tried to look at the whole picture and did come up with 10 recommendations overall. We've highlighted the treatment-focused ones here in this slide as critical themes, and certainly, as we've already emphasized, increasing naloxone availability, increasing the capacity for medication-assisted treatment, and trying to match individuals with the best chance of success to the 3 different types that we'll go over in a bit, increasing coordination between behavioral health, substance abuse, these medication-assisted treatments, and the physical health plans, the physical health providers. Primary care is critical. Law enforcement collaboration with healthcare stakeholders is something that we really hope to emphasize a little bit with the drug courts that we'll be talking about for the VA system, and in general shifting the correctional system from a source of the problem to a part of the solution. These are the kinds of things we'll be reviewing today.
Well, thanks. I have the results of the first polling questions, so let's look at it. For the answers given by the audience just tabulated, education about prescribing, 56% say that's the limiting factor, 12% say lack of patient demand, 8% say their time allotment, 19% say insurance reimbursement, and 5% say they don't support MAT. Do any of these surprise either of you guys?
Well, I think I'm surprised by a couple of them. First, the 5% who don't support MAT, and hopefully they'll find this educational perspective that we provide them helpful to them. And then, of course, the large number that really do feel they need education at this point, considering these have been available now for at least 10 years or so. So I think that this will be quite important. I think the other thing to emphasize is what's coming up in the next slide, which is what's come from a national survey that was conducted by SAMHSA.
Go right ahead.
Okay, well, this was in 4,000 clinicians that were surveyed in 2018. 75% of these had prescribed buprenorphine, so these were experienced, and the mean number of patients they had prescribed it to was 26, 27 patients just in the past month. So these were experienced providers, and that 13% were prescribing at or near their limit, the limits being 30 and then 100 and most recently 275. What's cited as the barriers is somewhat surprising in this, though, which is lack of patient demand, because most rural areas, most cities are talking about how there's more patients that want the treatment than there are providers to have it. And this may reflect a national trend where the average number of patients that are treated by providers is less than 5. So we have a somewhat unusual sample, perhaps, in these 4,000 providers here. The other issue, of course, was time, which was something that's shared with the survey we had here, and the insurance reimbursement, which again was something that was shared in the people who are watching today, that these are two other things, but have actually improved quite a bit from what they were even 5 years ago, certainly in terms of insurance reimbursement, that's much more common than it had been.
So with experienced providers out there and licensed providers out there and patients seemingly needing to find a provider, do you see any role for telemedicine in bridging this gap?
Telemedicine is one of the things that's been quite extensively used now within the Veterans Administration systems. We have a program in Houston, for example, that's providing telemedicine care, and in particularly the behavioral components of this care, because many patients are getting the buprenorphine but not getting the counseling you'd like to have with it. And telemedicine offers the opportunity to get that wherever you want, whenever you want. You can get it at home, you can get it at 2 o'clock in the morning, and in fact we have some places that are a couple of time zones away, so it in fact facilitates that. But we have, I think, real opportunities, certainly within the VA, where prescribing the buprenorphine is still a bit of a challenge. With methadone, of course, you're quite geographically restricted. With naltrexone, you're not restricted in the least in terms of prescribing it either. But one of the things that needs to be addressed is meeting with the patient directly for that first dosage of buprenorphine, which is the most common type of treatment that patients want.
Thanks. We're going to go over to Learning Objective 1, which is recognize the risk of relapse or death among incarcerated individuals with untreated OUD upon release. So that's our first learning objective. And really, if we look at the criminal justice system, and I think that's the slide is up there, the best way to discuss this is to bring in Tobias Wasser, who's the Chief Medical Officer at Whiting Forensic Hospital in New Haven, to share some of his insights. Welcome, Tobias. So, Tobias, what's the approach that many correctional facilities use when confronted with patients with OUDs?
So, unfortunately, many correctional facilities don't have sufficient resources or are not investing their resources in appropriately treating OUDs. But there are some groundbreaking work being done both in Rhode Island and in Connecticut, where correctional facilities have partnered with existing OUD treatment facilities in the community to provide medication-assisted therapy within the correctional facility itself. And through these programs, there have been demonstrated improvements both while the individuals in the correctional facility in terms of their decrease in disciplinary tickets or other measures that demonstrate sort of troublesome inmates. And then upon release to the community, there's a lot of data that demonstrates that they have decreased rates of relapse, they have increased rates of connection to treatment, and overall decreased rates of recidivism, both of which are measures that are, of course, we as providers are interested in decreasing relapse and increasing connection to treatment. Correctional facilities are interested in having well-behaved inmates who don't come back. and those tend to be the selling points to engage our counterparts in the correctional system to partner with us in these sorts of endeavors.
So what are the major barriers to MAT in your patient population?
I think some of the major barriers, one is resources. So it's an upfront cost, either to create these partnerships, create the time for them, or to pay for the individuals who have the expertise to provide the services, whether Suboxone or methadone. Obviously, correctional facilities often have limited resources, so to provide the upfront capital to pay for additional providers or to pay for the training so their existing providers can be Suboxone certified, for example, it requires an upfront cost, and you need a partner who's willing to provide the upfront cost in order to obtain the downstream benefit. I think a second issue in general is just time and the ability to work with a difficult population. It's not everyone who, it's hard enough in our, sort of the general psychiatrist shortage throughout the country to recruit any psychiatrist, let alone to recruit addiction trained or addiction certified psychiatrists who are willing to come work in a correctional facility is an even more narrow niche, and that presents another barrier.
Are there data that you can refer to that would compare methadone maintenance or MMT to forced withdrawal in this population?
Yeah, there certainly is data that demonstrates that methadone maintenance is clearly superior compared to forced withdrawal, and that forced withdrawal leads to an increase in a number of poor outcome measures, again related to relapse, increased difficulties while the individual's in the correctional system, and an increased risk of recidivism upon return to the community. So there's no doubt that MMT is a preferred treatment option, and that forced withdrawal causes a number of problems for both the individuals themselves while they're incarcerated and upon release, and for the facility itself.
What's so remarkable about the results in Rhode Island?
I think Rhode Island was one of the first programs to really pioneer, to study, and to publish their research on this partnership between an opioid treatment facility that was pre-existing in the community and to partner with a correctional facility. So that was really, it was pioneering work because they were really the first to do it, to study it, and to demonstrate these outcomes that I'm describing now that are now pretty well understood by this community. So I think that's what made it the sort of revolutionary work in its own right.
Well, it's optimistic, and it just shows that we can make a big difference in these special populations.
Exactly.
What are the high points of the results?
So I think the highlights of these results were, one, the partnership between the community agencies and the correctional facility, which was one of the first programs to demonstrate that this could be effective. I think there was a significant increase in the number of inmates who were connected to medication-assisted therapy, whether that was buprenorphine, naltrexone, or methadone. And probably the most significant result was the reduction in mortality. So there was a demonstration in this study that upon release from the correctional facility, there was a 60% reduction in mortality for those individuals who were connected to medication-assisted therapy compared to those who were forced into withdrawal.
That's just great.
And that's obviously a huge finding.
Thanks, Tobias. Thank you very much for being with us, and we'll bring you in later as well for our questions and answers. If you have any questions about the forensic population, please send them to Dr. Wasser, and we'll see you soon in the Q&A. Thanks again. Yeah, thanks, Tobias. This is great to see you at Whiting Forensic, and thanks to Yale as well for supporting the work at Whiting Forensic. We'll move on to our second objective, which is the veterans, applying this data, MAT, to special populations of veterans in the VA system. Can you fill us in, Tom?
Certainly. I think that, as you see in the next slide here, the veterans in opiate use disorder treatment often do get medication-assisted treatments, and the assessment for the VA overall was 66,000 veterans had an opiate use disorder, which is almost certainly an underestimate. because soldiers returning from deployment often experience chronic pain, which is comorbid with post-traumatic stress disorder and traumatic brain injuries. And this markedly increases their risk for opiate use disorder because they're often on pain medicines for 2 years or more when they first appear at the VA. Yet only 25% of veterans with opiate use disorders are being treated at the VA hospitals with medication-assisted treatments, which is still quite low when you think about that the resource is readily available within the VA. So I think that we're still seeing that there's a challenge within the VA system at getting these treatments more available to them.
Thanks. Brian, you run the psychiatric emergency room at the VA in New Haven and teach at Yale. Can you tell us a little bit about the VA program that you run?
Sure. So at West Haven, VA Connecticut, we're very proud of what we're trying to do. And as Tom just mentioned, according to that study, only 25% of veterans were on medication-assisted treatment. So we're trying to change that at VA Connecticut to get access to medication-assisted treatment for more veterans, with the emergency room being one of the primary points of entry for many of the patients. So on the slide here is a brief overview of some of the resources that we have. I'll discuss the psychiatric emergency room in a little bit more detail briefly, but basically, as it relates to medication-assisted treatment, there are a few major things that we do. We have a psychiatric emergency room. Once patients enter, then they can go to a daily clinic where they can continue to get buprenorphine on a daily basis. If needed, they can be admitted to our psychiatric unit before that. And then following that, we have access to a buprenorphine-only clinic. We have buprenorphine in primary care. We have telemental health that we're trying to get access to buprenorphine to patients who live a little bit further out. So we have a lot of resources on the back end. And these are some of the things that we offer. And of course, AA and NA is referred for all of our veterans. We can go into a little bit more detail about the psychiatric emergency room. So we have a dedicated, locked, 24/7, 365 psychiatric-only emergency room, which is separated from the medical emergency room. The medical emergency rooms are very common among VAs, but psychiatric emergency rooms are not very common at VA hospitals. We're one of only a handful in the country. So we're able to provide 24/7 care to any veteran who comes in by an attending level psychiatrist 24/7. We're staffed by approximately 30 MDs, all psychiatrists, and all 30 MDs are required to have a buprenorphine waiver. So when veterans come in with an opiate use disorder, we're able to take care of the veterans at any time of any day, and we're able to discuss with them medication-assisted treatment at any time.
It's a just amazing resource, and really quite remarkable, and I'm sure it's fun to work there too.
There is never a dull moment at the psychiatric emergency room, I can tell you that.
So could you tell us about MAT and why it's so important to initiate MAT rather than just detoxifying a patient?
Yeah, so that's a great point. So detox is not treatment. That's something you may hear again throughout the remainder of this. But this is a study on the screen where they followed people for a year. There were two groups of people. Both groups had opiate use disorder. Okay? The first group, which is the group in orange on the slide, they were not given medication-assisted treatment and maintained. They were simply detoxed, and they were sent on their way. The group in blue at the top, they were initiated on buprenorphine and maintained on medication-assisted treatment for the duration of the study, which is 1 year. So you can see on the vertical axis, these are the number of patients, and on the horizontal axis, this is time. So the study was 1 year. Of the people who were just detoxed, and you can see here, the rates of dropout were incredibly steep. By 2 months out, everybody had dropped out of treatment. And what's not shown on the slide is 25% of the people involved with that had passed away by the end of the first year, which is remarkable. And you take those who were initiated and maintained on medication-assisted treatment, you have quite the opposite. You have 75% who were still involved with treatment a year later of those who were maintained on medication-assisted treatment. So the moral of this study was detox is not treatment. To just simply detox a patient and send them home, generally speaking, is not helpful.
So I like to hear that because it's 2018, and in 1978 we showed the same thing, Herb Kleber and our group at Yale, with clonidine. If you just detox people and send them away, nothing very good is going to happen.
It's two separate problems. The opiate withdrawal is a problem that can be treated, but that does not treat the underlying opiate use disorder, which is what medication-assisted treatment targets.
So are there patients that you do detox?
Sure. So there are special populations of patients, and at the VA, I can give you a perfect example of a patient who we may not titrate up and maintain on buprenorphine. We might do extended release naltrexone, which would require a detox instead. So for example, our homeless patients. So homeless patients may not have ready access to come to the VA once a week or even a community clinic. They may be very difficult to track down. We have a homeless team at the VA who goes into the community and sees patients wherever they are. And if you only have to worry about a once-a-month injection of extended release naltrexone, that may be a far better option for a special population like that.
Yeah, I mean, in our own work with impaired health professionals, we'll detox anesthesiologists who are opioid use disordered and put them on injectable naltrexone.
Yep.
So can you tell me the process? You know, what's your procedure for initiation of buprenorphine?
Sure. So again, psychiatric emergency room 24/7, 365. Veteran comes in, they get a full workup. They get full history, physical examination, lab work, urine drug screen, and then they typically get observed overnight. If the history is consistent with an opiate use disorder, then we will discuss when was your last use, what have you been using, and when will you be ready to be initiated on buprenorphine. We will then initiate buprenorphine when the time is ready. We can hold them an extra day or two if needed. We would hold them for that day, get them stabilized on a maintenance level dose of buprenorphine. When they're ready to be discharged from the emergency room, we would get them to our daily clinic to see a provider every day to continue on buprenorphine until they can ultimately get into our buprenorphine clinic to be followed as an outpatient. So those resources on the back end are critical. If I'm going to initiate buprenorphine in the emergency room, I have to know that I have a place to send those veterans. And at the VA, I do.
When you initiate, do you always initiate at 2 to 4 milligrams?
That's usually our protocol. So, and you know, doctors will often obsess about, well, when can I give it? When is it too soon? Just ask the patient. The patients typically know they've taken buprenorphine before. They don't want it early. They don't want to wait too long. They usually know. We will usually start 2 or 4 depending on the patient and then titrate up typically to 8 on day 1.
Thanks. I think that's really helpful. And Tom, I mean, how does this all work together? There are 4 FDA-approved treatments. Can you help us understand them?
Yes, certainly. I think when you look at these treatments, there are really just 3 agents we're talking about, which is methadone, buprenorphine, and naltrexone. And the way they fit together is that methadone is a full mu-opioid agonist, as shown on this slide. It's a oral solution, can be a tablet, can be a powder, but in general requires the patient to come in every day to get it, and take-homes are an issue. Buprenorphine is a partial mu-opioid agonist. What that means is at low dosages, it is methadone-like and it has analgesic properties, but as the dosage is taken up to the typical treatment dosages that we use, of say 8 milligrams, it is an antagonist, just blocks other opiates. It also blocks itself, which makes it extremely safe. Comes in a sublingual tablet and has been used for analgesia purposes, but it's, again, as a treatment for opiate dependence. The next formulation, which is buprenorphine with naloxone, is the more typical way that it would be used, is once again not just the buprenorphine, but with a mu antagonist built into it. What that most often is for is if the buprenorphine is injected, the mu antagonist will precipitate withdrawal in someone who's dependent. So
naloxone.
It is the naloxone, exactly. So it's meant to be essentially a diversion-resistant formulation. It's typically given now as a sublingual film because there still were problems with the pills in crushing the pills and snorting them, which will give you a high. Finally, there's naltrexone itself. Naltrexone's the pure opioid antagonist. You have to be detoxified first. You can start buprenorphine when you're in withdrawal and it will relieve the withdrawal, but that's not true of naltrexone. And there's an injectable formulation of it that you need to give only once a month. And as we've talked about, there's special populations for this. But in general, it's the ideal treatment, but you have to go through the detox first.
Thanks. That's very helpful. What do you think about the comparable efficacy and the studies that recently have been reported? XBOT.
Yeah, XBOT is certainly one of the most important ones that came from the United States. There's another one that came from Norway that was in JAMA Psychiatry, and they both had very similar results. There were 24-week open-label randomized controlled studies, and they compared the effectiveness in outpatients after an inpatient induction onto either the buprenorphine or the naltrexone. Now for the naltrexone, that was particularly important because it was a detox that they needed to go through, and outpatient detoxes are possible but not easy. They then got either the sustained release injectable naltrexone or they got daily sublingual buprenorphine. And in this comparison, what was found, remarkably, 72% of the people got on to the naltrexone, so that the inpatient detox was success. The 94% for buprenorphine is not surprising. It's very easy to get on buprenorphine, and there was a big difference there. Among the 24-week participants, both medications were equally safe and effective. So when you got on this was a somewhat surprising finding that the treatment retention out to 6 months was the same for buprenorphine and the injectable naltrexone. Now, there have been more studies since that time looking at now an injectable naltrexone. And I think the next slide that we have does present some of those data. And
injectable buprenorphine.
With the injectable buprenorphine, and what you're seeing here is the red bars on this are the placebo, which did terribly over the 6-month study. But when you were giving the injectable buprenorphine, there were 2 different ways it was given. One was 300 milligrams once a month. The other was 300 milligrams at the beginning, but then switched over to 100 milligrams, so a significantly lower dosage. And what you can see by comparing the black bars to the green bars is there's really no difference. So there is, in fact, probably a very good rationale to take patients and switch them over to the lower dose buprenorphine, which potentially will make it easier to eventually discontinue the buprenorphine, which it is an opiate-based medication. You still are going to have some opiate withdrawal at the end of it when you discontinue it, which of course is the critical difference from naltrexone. You discontinue naltrexone, no withdrawal symptoms, but having those withdrawal when you discontinue the buprenorphine does keep people coming back.
So thanks very much for that review. I'd like to switch a little bit to talk about the fact that, simple fact, I mean, it was brought into the public eye in the most recent Demi Lovato event, covered widely in the media. There are many patients that overdose and come to treatment after overdose. And naloxone has been essential in saving lives and addressing the opioid overdose epidemic. What do you think we need to know about naloxone and its role in this epidemic?
Yeah, so you can think about it as 3 separate problems. You can think about it as an opiate use disorder, which is a chronic lifelong problem. You can think of it as the opiate detox, which is what we've spoke about. And then there's a third problem, which is an acute overdose, which is what will kill you. So naloxone comes in with that third problem, which is the acute overdose, which is what will kill you. Naloxone is a life-saving medication when administered for an opioid overdose. So you have an overdose, you stop breathing, you're administered naloxone, you save your life. The other 2 problems are still there, primarily the first one, which is the opioid use disorder, that the naloxone itself does nothing. Just like detox is not treatment, well, overdose reversal is not treatment for the underlying problem, but it is a life-saving measure that without it you would have lost the person anyway. So as you can see on the slide, there are several different formulations of naloxone. There's an injectable, which could be given by a paramedic, an auto-injectable, which can be given by anybody with some education, and a nasal spray, which also can be given by somebody with some education. I would encourage everybody in the audience, if you're interested in learning more about this, that last bullet down there, that SAMHSA Opioid Overdose Prevention Toolkit is an amazing resource that's available on the web with tons of information about this.
You know, that's very helpful. And the Humphreys model of thinking about how to prevent deaths, you know, over the next decade, they emphasize the importance of naloxone and its availability. Like, is naloxone in crash carts?
Right, so the VA in Boston is now looking at putting naloxone rescue kits, or has recently put naloxone rescue kits, made it available right there next to anywhere there would be a crash cart, or anywhere where there might even be a defibrillator, basically making it available to anybody who can provide emergency resuscitation to someone who might need it. And the VA is looking at expanding that all over the place among all VA hospitals all over the VA. But then you get into the discussion of where do we end, right? There's defibrillators in airports and other places, and what might come from putting naloxone and having it available in a large variety of areas that anybody can access in the event that someone might be overdosed.
It's a relevant question. If you when you think about naloxone, do you think of it like a Heimlich maneuver or CPR? I mean, most people know how to do a Heimlich maneuver, and many people know how to do CPR and have saved lives. Should everybody know how to administer Narcan?
Right, so I would say there's one key difference is that in general, people who need a Heimlich maneuver don't have an underlying disorder that predisposes them to continue to choke all the time. Having naloxone available to everybody will save lives, but still that key part is what to do now. You've resuscitated them, you've saved lives. Now, how do we get them into treatment because they're still at risk for having that happen again without continued treatment?
I agree. And, you know, the Surgeon General has emphasized this, and I'll only say that for people who are watching, if you do give Narcan, remember, if you're not in a hospital, call 911.
Absolutely.
This doesn't last long enough.
Doesn't last long enough.
So we'll go to learning objective number 3, heightening awareness of novel programs that are having an impact in the community. It's really critical. In addition, we want to look at what we talked about before, share 3 more novel programs. And so, Tom, can you start with the Veterans Program?
Certainly. So the question is, what is a Veterans Court? And it's a hybrid of the drug courts, which have been around for almost 20 years now, and the mental health courts, which are somewhat newer innovations where people who are, when charged with something, are in fact given options to get into treatment for it. And many of the people, of course, have both. So it's a community collaboration. It's comprehensive treatment through the VA, and the VA does have a lot of resources. And I think the picture on the right is probably a very telling one of there's somebody who's had a leg amputation, but unfortunately has become chronically opiate dependent related to that and to its treatment. It's a non-adversarial system. It utilizes a lot of peer mentorship of veterans helping veterans. The length of stay in these programs is relatively long, up to 2 years, and it's goal-driven, phased progression through it, and the typically successful completion results in great legal benefits to the veteran because they will have the charges taken off their records that may have brought them in. The next slide here is, how do we evaluate the success of these courts, though? How have they done? Well, what are the desired outcomes? What are the challenges in measuring these outcomes? Are some of the things to consider. The desired outcomes certainly would be a reduction in criminal recidivism, successful completion and discharge of these 18-month to 2-year programs, sustaining that treatment and recovery goals over the long haul. I mean, particularly for the mental illnesses, that those need continued medication management, and of course, as we've been talking about with the substance abuse, we have our medication treatments for opiates that are particularly good. Resolution of psychosocial issues are important. How do you measure all these things? These have always been an important outcome because if you don't have measurable outcomes, you don't know whether it's working. And initially there was very little research available, but now there has been. There have been national surveys, including the one I'll present briefly here. Drug court research, it's different than mental health. So here now looking at the predictors of incarceration, this is people, veterans before they enter into these court systems and what's associated with them subsequently getting incarcerated again. First thing is homelessness. Lasting more than 6 months to 1 year is a higher incarceration rates. Being a student and in the active military or in VA vocational training, interestingly, you'd hope would all be positive, but unfortunately are associated with higher incarcerations. Moderately bothered by cravings in the past 30 days, of course, makes sense. These are drug cravings. Having a history of substance abuse treatment, of course, if you stay in it, it's going to have a good prognosis, but if you've had it before, it means you've got 2 things wrong with you at least, mental health and substance use. And then if the Veterans Judicial Organization has got issues with that. Now, of course, if you look at the post-Veterans Court entry, what things are associated with incarceration, most important thing about lower incarceration is stable housing. Most of the other things with higher incarceration, including parole violations, longer stays in the program because you've repeatedly made violations, end of participation due to a new arrest, and due to a transfer in the legal system, that is, you go to a more severe level of the legal system, which might be a federal charge against you, and then requiring mental health follow-up but not undergoing treatment. You got to get into the treatment. So these are some of the issues that have come up. I think that the next slide we have there.
So I think what you did that was really remarkable was bring the whole idea of Veterans Court into view. Like, I remember Janet Reno starting drug courts in the state of Florida and speaking. I think I spoke at the first drug court conference, and it was a revolutionary concept, almost like mirroring what we do for impaired health professionals by giving them a monitoring system, carrots and sticks, and all the state-of-the-art treatment that's available. So we're going to go now to our remote, this time to West Virginia University in Morgantown, where my friend Jim Berry has created a really interesting and novel program called COAT. Welcome, Jim. Can you start by telling us a little bit about the program in West Virginia that you start and run?
Sure. So it's really a program that was born out of necessity back in the early 2000s when we in West Virginia became inundated with a number of people seeking help for pain pill addiction. Our traditional method of just detoxing folks, telling them to get to meetings and then come back and follow up with their therapy simply wasn't working. And then we had the opportunity to start prescribing buprenorphine in around 2004. And realized that this medicine was very helpful in helping satisfy and tone down the cravings, helping people feel better, keep them from getting sick, so that then they can engage in all these other important elements that we know have worked for a long time. And so that was working. Then we quickly realized that if we were going to see these folks on an individual medical management appointment, that we weren't even going to scratch the surface as far as the demand. At that point, we started utilizing a shared medical model, where we would see people in a group setting for their medical management and then connect them directly with a therapy appointment right afterward. So the model now as it exists is it's a 30-minute medical management between 8 and 10 patients, and that's about 30 minutes, followed by an hour of group therapy. The other thing is we require people to attend at least 4 community-based peer support group meetings a week as well.
So why do you call the program COAT?
So COAT, it stands for Comprehensive Opioid Addiction Treatment, and the idea being that medication is just one element of that treatment, but we're trying to make it comprehensive by adding both the biologic domain, psychologic domain, and social domain.
Have you ever heard of a program like it?
Not exactly like this. Over time, I think some other folks have also been utilizing the group-based model that we've been able to kind of see across the country. That's sort of grown up from a grassroots, and then also some elements of the phase-based model as well.
So the kind of program that you've developed can evaluate and treat large numbers of patients. That's really remarkable. What are the phases in the COAT program?
So there's 4 basic phases, starting with the beginner's phase, where people who are coming in straight off the streets, and they come weekly for the first 90 days of abstinence. Once they are able to collect 90 days and their level of functioning is well enough to graduate to the next stage, which is our intermediate stage, which is a biweekly group until they get a year. Once they get a year, then they graduate to a monthly group. And then once they get 3 years, then they're able to graduate to a bi-monthly group.
So it's highly structured, and you do have these different phases, but what are the outcomes like? How many people start, and how many people have you been able to retain?
So our most recent data here at our Morgantown site in Morgantown, West Virginia, we're treating about 500 patients, and of those 500, for those who are able to be in the weekly group, we got a retention rate of about 50%. And those who are able to graduate to the beyond weekly group, the retention rate goes up to a little over 80%. And then as far as abstinence is concerned, we've got some pretty good success as far as that goes. For folks, we got about 71% abstinent rate for greater than 90 days right now.
So that's really remarkable. I mean, what about relapses? What do you do when someone has a relapse?
Yeah, so as we understand, the disease of addiction is a chronic relapsing disease. We understand that's part of the process, so we try to help people learn from their relapses, and they will either continue in the phase that they're in until they're able to collect those number of days sober. Or if they continue to relapse, then that might be a need for a higher level of care, meaning transferring to one of the higher phases or the more intense phases, or even more intensive, such as residential treatment if necessary.
You know, I really like the idea that you have a comprehensive program and it's biopsychosocial. That's all quite remarkable. How do the guiding principles affect care on a daily basis?
Right. So again, we really appreciate that we're trying to address every one of those domains. And fortunately, we have a great medication with buprenorphine as well as naltrexone and methadone, but we primarily use buprenorphine to address this biologic domain. But also, we recognize that that is not the sum total of an addiction disease, and trying to really address the psychological and the social, making use of the community-based peer groups, we believe has been tremendous in keeping people into recovery. One of the things that have been so remarkable that we've been able to notice over time is sort of the synergy that takes place within the group setting, and how much of a healthy culture goes a long way in helping people whose lives are simply chaotic when they're living at home.
You know, I mean, you're a prominent addiction medicine and psychiatry physician from a major academic medical center. Setting up a program like this makes a lot of sense, but could somebody do this in their own community?
They absolutely can do it in their own community, and we've seen others do it and replicate the model in their own community. And if you think about it, if you're a primary care physician out there trying to do the best you can, you are able to get waivered and prescribe a medicine like buprenorphine, and then you're able to make use of the community peer support groups that already exist. They're all over the country. There's AA and Narcotics Anonymous, Celebrate Recovery, Smart Recovery. Typically, every community has some of these groups. They're free, so you don't have to worry about insurance paying for them. Usually there's peers who should be available 24 hours a day, 7 days a week, that can be with that patient who's helping you as the physician help this person really engage and store up a good recovery program.
You know, it also, having a program like this at West Virginia University, you've probably been able to influence all kinds of practitioners and trainees and fellows so that they've learned about addiction and addiction medicine and learned that addiction's a disease and that we can treat it. Has that worked for you there?
Absolutely has. One of the wonderful opportunities that we have here as a teaching setting is not only do we have medical students come and rotate through our program, but we also have resident physicians of all disciplines who are able to see this model. And what makes a big difference in the lives of these clinicians and future clinicians is to really see people get better. Because you know as much as I do, if they're just seeing the worst of the worst in the emergency department who continue to relapse and don't see people get better, then they can have a skewed opinion. But being able to see people work through these stages of recovery and build a lot of recovery into their lives makes a difference in these clinicians. And so we see primary care physicians here now replicating our model and being able to do that. And we see others as well throughout the state.
Well, I want to thank you for coming on today. It was just great. You know, I really appreciate your program, and I appreciate that you shared it with us so openly, and it's very encouraging. It's encouraging to clinicians everywhere to know that programs can be set up, they can work, and they can integrate MAT with community resources in a way that's cost-effective, safe, and helps people recover. Thanks again, Jim.
Thank you so much, Mark.
Brian, let's head back to the Northeast, and maybe you can fill us in on what's happening with the police department in Gloucester.
So people are constantly trying to look for unique and novel ways to approach the opioid epidemic. And in Gloucester, Massachusetts, they're really taking a pretty novel approach where they have a voluntary no arrest program. So they're offering a direct referral to suspects, if you will, who the police encounter with an opiate use disorder, whereas instead of arresting them, which may have been the current practice, they're now offering them voluntary referral to detox and treatment. And remarkably, in the year of this program, from June of 2015 to May of 2016, you can see the numbers on the screen. 94.5% of the people that they encountered, they were able to offer direct placement into a program, which those numbers would be higher than, I would guess, most people listening here. If you have a patient who presents to you saying, I want treatment for my opiate use disorder, I'd be hard pressed to think how many people out there would be able to get 94% of their patients into treatment. So this is a pretty novel thing, and we'll see if this spreads. And we'll soon know what the success has been by looking at some long-term outcomes.
So, you know, it's not unlike coerced treatment for impaired health professionals, where a doctor might be said, you know, like be in an evaluation, and the evaluator says, you're going to enter treatment because you can't practice medicine impaired like this, and you get high 90%.
Right. The carrot and the stick can work.
And you know, even in other occupations, maybe airline pilots or Secret Service, or there are a whole group of them.
There are, the most intriguing of which was a patient that we were treating in New Haven who worked at the nuclear power plant, which was always interesting. Make sure he take his naltrexone.
You know, I think that the clinicians that have treated people for over the last 40 years have lots of stories like that.
Yes.
And we're really grateful for the MATs and for being able to retain people because of either an employee assistance program or the Board of Medicine, or in this case, the police, or in the VA's case, maybe the VA court.
Yes.
So, you know, I'd like to say this has been a great discussion. I know there's a couple more things that I'll throw at you, but I did want to thank Tobias and Jim and Tom and Brian for being here. When you think about what clinicians should be doing differently, and what are the main things that you've learned in your career working in opioid use disorders, you know, you and I were trained by the late and great Herb Kleber.
Yes.
And started in a field that didn't exist, and here we are. And what can you share about those insights?
Well, I think that we've got put up on the slides a couple of things that are most important, that we do not only have to prescribe opioids less so that we're not making a problem by being physicians, but that matching patients up with these medication-assisted treatments and the psychosocial treatments, which can be delivered in a variety of ways, including the telemedicine, telepsychiatry approaches. The other issue that I think would be critical to recognize is that the VAs do have a model for integrating correctional programs with effective treatment, and that needs to be thought through much more carefully. It's not just the drug courts that are needed, but it has to be integrated with mental health services, because most of these patients have both disorders.
You know, I mean, it's a really interesting point. In the Humphreys analysis of the opioid use and overdose crisis and reducing deaths, pain medications were not seen as a major, you know, changing prescribing was not seen as a major advance at all. In fact, of the advances, just going by memory, was naloxone, MATs, psychosocial treatment. And no one advance could solve our opioid problem, but if you added them all together, you could make a substantial difference. But it is a really interesting time that we're in, and we've learned a lot. I learned a lot by going to West Virginia. So I was with Jim, and I got to see how they've gone from Morgantown and developed programs around, kind of cobbled together resources and almost developed a model program based on charitable and available resources. I mean, you're a younger guy in the field. Again, similar training. I mean, you're MD, PhD, and you have both the science and the application. What have been the things that you've taken away over the last few years in your career that would make a difference for people watching?
Yeah, I think, so for people who are watching, I think think about the system that you're in and what smart, as you can see on the screen, changes can you make? Even if it's a small thing, what can you do? At the VA, we're constantly trying to improve, constantly trying to change, constantly trying to do things. And we set small goals for ourselves. We have to get all the doctors' X licenses. We have to do this. We have to do that. And over time, as you said, chipping away at each one of these little things can make a big difference. So think about the system that you're in. Set a short-term goal for your organization and for what you do in your practice. And how is it that you can then overall, over time, make a difference for more patients?
You know, I think, hearing from Tobias and in a criminal justice-like setting, or Jim in West Virginia ravaged by the opioid crisis, or you in a long career in multiple sites, including the VA, and you, we can see that we have tools and we have evidence, and we should apply both the tools and the evidence to make a difference here.
Completely agree, and I think as the SMART goals implies, when you do decide to have a new intervention of any sort, you have to measure outcomes. Otherwise, you can be terribly misled by anecdote.
Yes. So I want to thank CME Outfitters for their work on this program. They've been very active in educating clinicians on OUD and the opioid crisis. Many of you who watching today have probably seen their DEA museum lectures, which I also had the chance to moderate, and both of you had the chance to participate. And they provided credits for the DEA broadcast, which was seen around the globe. Brian and Tom, thanks for your work here today and your
You're
careers.
welcome.
You've made a great difference, and the evidence that people talk about in the field comes from your work and other people that we've all trained and interacted with. I encourage everyone to visit www.cmeoutfitters.com for a comprehensive list of clinical resources, outcomes research, news, additional educational activities for both providers and also for patients. And CME Outfitters is now on YouTube, so check out their activities and patient education there. So let's jump in. I have a question for Tobias. Working in corrections, we have problems with contraband, smuggled in buprenorphine. Therefore, we utilize naltrexone while incarcerated and then provide naltrexone injectable prior to release. Are there statistics yet as to whether or not this is a proven, safe and effective treatment approach over time?
Well, thank you very much. That's a really important question. Clearly, in any correctional environment, you do have to be much more careful about contraband and what's coming in and what's coming out, and the risk for diversion is very high. So these are important considerations. I think, there's, as we discussed earlier, there's evidence from Rhode Island about the use of naltrexone as one of 3 MAT tools, and there's evidence that that can be helpful. And using Vivitrol, the long-acting injectable, seems like a very sound approach upon the time of discharge. I don't know of any evidence that's looked specifically just at naltrexone or Vivitrol as an option, but I could certainly understand, given the challenges we talked about in correctional environments, why that would be a really sound strategy. I don't know if any of my other panel participants are aware of any research, but I'm not.
The only other question would be whether there's research of comparing in a prospective way, and I said no, but it's a really good question.
Well,
do you have, like, what would you say?
There have been studies
Incarceration.
of looking at people post-incarceration who've been put on naltrexone. Chuck O'Brien and the group out of the University of Pennsylvania have done that with federal probationers and shown that it had an extremely good outcome. So that this looks like a very viable opportunity to be taken up not only within the federal system, but within the local systems. And they began piloting that a couple of years ago in Philadelphia. There were certainly programs that we had quite a while ago with oral naltrexone, right, which was one in which they were work release programs and the patients came in 3 times a week, and we did have outcome data. There was 3 programs. One was again in Philadelphia, the other was in New Haven that Herb Kleber and I ran, and the third one was on Long Island. And those did have not a placebo control, but were in fact active follow-ups where they would follow people out to what were 6-month programs at that time. Of course, now the new drug courts that the VA has is out to 2 years, and the outcome data on those studies will once again not be placebo-controlled studies, but you can have comparative studies of those who enrolled in the drug courts and those who did not. It would be very difficult to do complete placebo control, but Chuck did do one, and that's published about a year or so ago.
That's really helpful.
Yes.
Thanks. So here's a question, and I'll address it to you guys. And I'm an internist. What is the best screening tool to recognize an opioid use disorder? And can you tell me more about the certification process for prescribing buprenorphine? What do you think about screening tools?
The best screening tool, first off, is ask the patient. They will often tell you. The other next best screening tool is get a urine toxicology. If it's got opiates in it and you're not prescribing the opiates, that will be a hint. And in particular, say if you're prescribing one opiate and you find a different opiate in their urine, that ought to be a pretty good hint also. So those are the simplest ones, just simply asking in the urine toxicology. I think the other question that I heard was,
like, would the DSM-5 offer anything?
Most of the time what you find in the DSM-5 is someone who is opiate dependent, and so they are truly in that sense addicted, meet almost all the criteria in DSM-5. So that while a measure of severity is how many of those criteria they meet, opiate dependence tends to be fairly severe in people, and so they'll meet a lot of them. The chronic pain patients who get treated, of course, those are the ones with the biggest
What's your
challenge
barrier
occurs.
for giving buprenorphine, like on a diagnostic, from a diagnostic point of view?
You certainly don't want to start buprenorphine in someone unless they're in opiate withdrawal, because if they are opiate dependent, you might precipitate withdrawal. You then, of course, have to distinguish opiate withdrawal from a bad case of the flu, because it wouldn't be useful to make somebody exactly opiate dependent. And so usually the combination of they have opiate withdrawal symptoms, which you can easily get from the cows or the sows, which are structured instruments for that.
Are any of those instruments like so easy? You refer to them as well in your talk.
So there are screening tests that are designed to screen for the possibility of a diagnosis, and then there is a more thorough history that you would do to then make a more accurate diagnosis. So certainly some of the things that Tom mentioned might be a screening test to do in your clinic, very basic things. If you suspect that someone has an opiate use disorder, then you might want to refer to those criteria in the DSM and say, okay, is my patient's life out of control? Is he compulsively using despite consequences? Is he craving? These are the things that you're then going to look for to make a diagnosis, mild, moderate, severe, and then that might guide what your treatment principles are for that patient.
Where would somebody watching find the cows or the sows?
So you can, it's very easy to find online to look up the clinical opioid withdrawal scales, and for other screening tests are also readily available. But I do want to get to the other question, sure, which was the certification for buprenorphine waiver. So there are organizations out there. I'm a part of one organization, and I teach one of the courses in order to get buprenorphine certified. It's an 8-hour course. 4 hours can be done in person and 4 hours online, depending on whether you want to pay or whether you want to do it for free, but it's even available for free. It does take 8 hours. Then you get a waiver through SAMHSA, and then you simply submit that to the DEA, and you obtain an X license. The X then goes in front of your DEA number. So if it's FF something, it would become XF something, and that would then give you the right to the ability to prescribe, order, and do other things with buprenorphine. I strongly encourage providers who are interested in this to become licensed. Even if you don't anticipate doing a lot of prescribing, the 8 hours that you'll learn is critical for your education as a provider, and also to be able to help you to take care of the patients.
Well, that's a good point. We have a question related to that, was whether you have to be a board-certified addiction specialist to prescribe MATs. So
to prescribe buprenorphine or extended release naltrexone, you do not. To prescribe extended release naltrexone, you just have to be able to prescribe medications. To prescribe buprenorphine, you have to be a licensed physician in addition to obtaining the X waiver, which is the additional 8 hours. For methadone, you have to operate within the confines of an opiate treatment program, which is a federally regulated program. So for methadone, you have to be in a specialized program to be able to do that. So there's sort of 3 different medications that we talk about and 3 different levels of regulation for those medications.
I want to thank everyone for sending questions. The staff is working full-time to collate them. We have a lot of questions coming in. Tobias, let me ask you, what's the cost of an MAT program in the forensic system? Do you have any idea of the cost?
You know, I think that's, of course, a really important question, but that's probably it's a little hard to answer directly, given that the number of ways in which it might be compensated for. So depending on whether it's funded solely by the Department of Correction versus a collaboration between a state Department of Addiction Services or a county level Department of Addiction Services, or if it's a collaboration between the Veteran Affairs Bureau and the Department of Correction. So it's a little too complex to say, you know, X number of dollars, but essentially it is the cost of the number of staff that are required, both to provide the prescriptions, provide the monitoring, and to ensure that there's collaboration between sort of within the correctional system and the follow-up on an outpatient basis.
Thank you. Let me ask you, Tom, since you work in neurobiology and have been a pioneer in vaccines and everything else, is there data that would help us in advance identify who's going to become addicted? And is there a way you might approach addiction risk?
It's an excellent question. This usually comes up in treating patients for pain. And the most important thing to do is avoid this becoming a problem by not treating people with opiates chronically for more than 3 months or so. And there's, of course, now specific guidelines from the FDA and CDC about quite time-limited use of opiates. The biggest problem that typically occurs, and this can be a dentist, a primary care doctor, or some other provider who generally sees a wide range of patients, is to give them a prescription for a month's supply of opiates, of which they use the opiates for several days and then put it in their medicine cabinet for their children to then take when they want to.
Would there be any genetic testing or screening for opioid-like genes, or is there anything out in the future?
There are genes that we've identified for pharmacogenetics, meaning that if you have this particular genetic polymorphism, you're more likely to respond to something like naltrexone. That's certainly been true with alcohol, and it looks also true with opiates.
Really?
But there are no genes that we've identified especially at high risk for making you become an opiate-dependent person, with the one potential exception of there is a polymorphism in the mu-opiate receptor. It leads to a 3-fold higher affinity of that opiate receptor. It has a particularly high prevalence in people from northern climates, meaning Finland, Sweden on the European side, northern China, Mongolia on the more eastern side. And in those groups, you have up to 1/3 of the people carry this polymorphism, and it accounts for a substantial amount of opiate dependence and alcoholism in those populations. Other than that, the other population that has a high prevalence of this particular polymorphism are Native Americans, because they actually are from northern China, and they carry this the way northern Chinese do. They unfortunately, for alcoholism, don't also carry the polymorphism that protects northern Chinese from alcoholism, which is one that produces these antabuse disulfiram-like reactions.
The flushing.
The flushing response. Native Americans don't carry that particular gene.
If I could just add one thing. I would say any prescriber who's thinking of starting either a benzodiazepine or an opiate, any potentially habit-forming medication, should know basic information about the patient for screening purposes. So if your patient has a history of a personal history of a substance use disorder, if they have a family history of a substance use disorder, they're more genetically loaded.
That's great.
And also if they have a history of trauma or abuse or a history of mental illness.
That was a really good one, trauma or abuse, because sexual, physical, and emotional trauma is so important in treatment settings.
Right.
And you always hear about that.
It's very common.
It's very, very common. So there are so many questions. The reality is that some of my patients don't want to take buprenorphine. Do you think the extended release option would change their mind?
My experience with buprenorphine is that the people who want to take a medication do usually want to take buprenorphine. The people who are on buprenorphine had a relatively low desire rate for taking the injectable buprenorphine. The place that we're hoping that it will in fact get more widely used will be in the criminal justice populations, right, because right now naltrexone is the only option that's often offered there, sure, and patients will turn that down. But I think that injectable buprenorphine in someone who doesn't want the oral buprenorphine would be a risky undertaking. You usually have to start with oral buprenorphine or sublingual buprenorphine first before you would think about injectable.
So I'm going to go through some of them quickly, just because you can see.
Yes, pages and
I
pages
really
of
feel
questions.
great about the questions. Can you give specifics on how you'd manage opioid withdrawal phase in the current day? Is there a best way to transition patients on injectable naltrexone?
I think the two things I'd want to emphasize with that is lofexidine has just been approved as a medication for treating opiate withdrawal. It is better than clonidine.
Herb and I reported that in 1980.
Yeah, it's remarkable how many years it's taken for this to hit the market, but it's now FDA approved. It's been used in Europe for about 25 years. It is much less of an antihypertensive agent than clonidine is, many fewer side effects, and you can give it at a fixed dosage. You don't have to constantly adjust the dosage.
That's a good thing.
Like you do with clonidine. So that would be my recommendation, that that's your base of treatment. And then, of course, other ancillary medications can be added. A large study was just completed in which they tried giving tiny doses of naltrexone as a way to decrease the duration of that withdrawal. They didn't find that it was any better with that. There is some data, though, if people are on buprenorphine before they start the detox, even if as little as a couple of days, that makes the detox transition easier than if they're coming off a short-acting opiate. That partial agonist property looks important.
But it's worth noting that that period of time of detox, if not done in a controlled environment, is such a high-risk time for the patient to relapse.
I agree.
Yes. Yeah.
I think it's the same. You know, you have to consider that for people who aren't retained in buprenorphine either, if they detox themselves.
Right.
It says, we're considering using NPs to help during the initiation of MATs. Do you have any suggestion or experience?
Well, the NPs first have a somewhat more extensive training. These are nurse practitioners than do the physicians. It's about 24 hours worth of training. It is available, and I've certainly trained a number of them so far, and they can in fact do a wonderful job with the induction. The challenge with buprenorphine is often getting off of it, not getting onto it.
I have two nurse practitioners that work in the emergency room with me who are both excellent, and they're a very valuable part of the system, and both are able to do it as well.
So, you know, just to follow with you, there's a question about the VA. What percentage of your OUD patients in the VA are managed with MAT?
So I don't know the overall percentage. I know we have a large clinic for buprenorphine, but I can tell you that of the patients who present to the emergency room, we try to get 100% of the patients on either buprenorphine or extended release naltrexone or methadone because we have a methadone clinic as well if that's what's indicated for them. But our goal is 100% of patients who present to the emergency room who will then be initiated or maintained on something at that point. Overall, we have a very high percentage, but I don't know the numbers of all of the veterans who come to VA Connecticut who have an opiate use disorder who are on maintenance. I don't know the overall number, but our goal in the psych ER is 100%.
So Tobias, just a quick one. Do you have any thoughts, just academic thoughts, on the co-occurrence of criminality and OUD? Is it to support drug problems, or what do you believe is the relationship between the two?
Yeah, I think most often, so, you know, in and of itself, in the majority of states, it is a crime to be in possession of certain illicit opiates, obviously, such as heroin, et cetera, or to be in possession of medications and using, you know, other people's medications. Oftentimes, a lot of what I've seen are individuals, if they're themselves using or they're misusing other people's medications, or they're engaged in illicit activities to support their own drug habit. So I think that is the most common reason that people with opiate use disorders end up finding themselves entangled with the criminal justice system.
Thanks. There were a lot of questions that I could summarize, as this is an expert panel. And what would you do about the opioid crisis? And what are your recommendations? And we've kind of summarized them, but we could, you know, you could take a first crack at this, and if you leave anything out, which is highly unlikely, one of us will chime in.
Well, I think that what's being done now simply needs to be done more and more often. Naloxone availability for overdoses, so we keep the patients alive. Making the prescription of opiates much more regulated in terms of giving what's needed to the right people and not for extended periods. I mean, logical.
We want to treat the pain patients.
Exactly.
We don't want to
overkill. Don't overdo it. And then, of course, making these medication-assisted therapies available. And the in spite of that percentage of physicians that say 15% of them are saying that there's not sufficient demand, that doesn't fit the overall status of this, particularly in rural areas where people want these treatments. Whether we can make them more available through telemedicine is going to be a challenge, because you do have to be licensed in that state in order to prescribe it with telemedicine. That's not true in the VA, but everywhere else it is, and how that's going to work out, I'm not sure.
You know, I have done work as a volunteer for the DEA and the Take Back Medications days. We used to have no way to even take back medications. You couldn't, you're advised not to flush them down the toilet. You're supposed to bring them to the pharmacy. At least the pharmacy now will take them. So some public health measures, and I do think like public health measures that we've used successfully in other drug crises. You know, we didn't have a death crisis, imminent use death for cigarettes. We had 440,000 people dying a year. And what did we do? We had education, just like you said, pain education and patient education and physician education about medications. We had prevention. There's very little in the way of prevention activities anymore. Prevention, when it's applied, is successful, is 100% successful. I know people who've come up to me and said, you know, this ad or that event in my high school or grade school made all the world of difference to me. And that's one person that's out of the realm of being drug available and possible. I think air, water, and environment are highly relevant. We did a 5-year State Department supported study on opium smokers in Afghanistan. And so if the husband smokes opium, the wife is next to the husband, and the baby's on the breast, you have 3 generations of opioid dependence. Only one was voluntary. So these are all things that we right now in the middle of a crisis, we don't have a chance to consider, but are really relevant. Brian, just for you.
Yeah,
sorry.
I just wanted to add, I think part of it also is the feelings that get evoked in family members and doctors and everybody who's surrounded by patients who have any addiction, but particularly an opiate use disorder. It's so important for providers to understand that this is a disease and this is something that affects people, and they don't want this problem. Just like nobody wants to have cancer or diabetes, nobody wants to die of an opiate overdose all alone in their bathroom. Nobody wants that. But unfortunately, symptoms of this disease often lead to the alienation of those who care about that person, loved ones. Even physicians and psychiatrists often get incredibly frustrated with the behaviors. So I think it's important as a provider to take a step back to understand that what this person is going through is a symptom of the illness, and not to allow your own emotions get involved, and to treat this person as a patient like you would with any other problem.
That's really helpful. Somebody asked me a question. Thank you. In managing impaired health professionals, and you know, we've reported the data. Bob DuPont and Tom McClellan and I is good 5-year data. It's important to note that in the state of Florida, there's even a peer-reviewed publication on the use of mandatory injectable naltrexone in anesthesiologists who want to return to work. So there's really easy, very available 5-year outcome data. Impaired health professionals have 5-year 80% return to work and sobriety, and we do use MATs, but not in all of the patients. Just a couple of quick ones, so maybe we can get through them in the last few minutes. Are there any issues with injection site reactions that are concerning to you? And
well, certainly with naltrexone, as you should be aware of, it's very important that you get it in the muscle tissue, not in the fatty tissue. So you do have to follow those instructions carefully. With the subcutaneous injections, they are meant to be subcutaneous, which is with the new buprenorphine. And once again, if you miss, it's not a good idea to, so that draw back on the needle. Don't inject it into a blood vessel, for example.
So how many times can you use naloxone in one person?
You can use naloxone
as many times as you need to.
You want.
And one thing that hasn't been touched upon, really hasn't been discussed very much here, is the fentanyl and the fentanyl analogs that have been incredibly common, and they're making their way into all forms of drugs, not just opiates, but also cocaine and other drugs. And sometimes it requires multiple administrations of naloxone to resuscitate someone, especially if they have some of those powerful opiates.
So that's really a good point, which is that because illicit drugs are illicit, and they don't come with milligrams on them or what's in them. They're both adulterants that could be active drugs or fillers, but there could be fentanyl in everything. 50% of the cocaine deaths in Florida are really due to fentanyl. And so probably the most logical way to approach it is if a person has shallow respirations and a weak pulse and looks like they're going to die or be in a coma with pinpoint pupils, that you give them Narcan, whether they say they took opioids or not.
They may have just taken cocaine.
Did you do that like in the New Haven when the 100 people overdosed at the Green? Did they give them all Narcan?
So that didn't occur at the VA, but I'm pretty sure that in the field that would be a standard of care.
You just give it to them.
No harm's going to come from that.
So just so everybody knows, for me too, I mean, I worked in the Yale emergency room, and we used to break open the Narcan vials, and we'd give people as much Narcan as we could. And it was hard at 0.5 at a shot, but that's not something that you need to worry about. But you do need to worry that Narcan is short-acting, and the drug that they took is longer-acting.
Right. If someone overdoses on methadone, one administration of naloxone will not be enough.
The most important thing for providers to recognize, by the way, is when they come in with a cocaine or methamphetamine overdose and they have pinpoint pupils, it's not cocaine or methamphetamine. They give you very wide, dilated pupils. And so it's an opiate that's on board.
So we had a couple of questions about the occurrence of alcohol and alcohol dependence in opioid dependence. And you have some thoughts about that in MATs.
Well, certainly the treatments that are recommended for both opiates and alcohol are opioid antagonists like naltrexone. So that with someone who has a dual addiction, naltrexone would be your ideal agent. It would be ideal to use it once a month, and that those people would really do quite well with that, even though for their opiate dependence, they're not going to be enthusiastic for getting that detox. You don't need an alcohol detox before giving naltrexone for alcohol, though.
Any advice for emergency physicians for initiating treatments? I mean, you could refer them to your work.
Yeah.
They could write to you. That's
Yeah.
pretty. You're like an emergency physician, but just happen to be a psychiatrist.
No, I mean, I am an emergency physician. That's what I do every day, but it is just psychiatry. But I would say the most important thing is the follow-up on the back end. There was a recent study by people at Yale, Gail D'Onofrio's group, about initiating the buprenorphine in the ER. That's fine, but what are they going to do on the back end? And if you're in a community-based hospital, people who are unfunded, you're going to have to partner with people in the community.
I appreciate it. This is, you can kind of see, this is a crisis, and really we appreciate everybody being here and sharing their own experiences and questions. It's important to keep the dialogue going. You can go to CME Outfitters and share the site. This will be permanently online, and you can download it and look at it and ask questions through the site. So thanks to my panel.
Thank you.
So just an amazing contribution, and you can see from the response that this was really an important effort. Thank you both very much. Thank you, Tobias, and thank you, Jim, in West Virginia.